Thanks, Mike, and thanks everybody here for listening to our story. It's not a story about us. I think it's much more a story about health in developing countries and what happened over time and how things have changed from, I think there are many people here also, maybe with some African or developing market or developing country roots, how things were totally in disarray, I would say, at the beginning of 2000, and how things have changed dramatically. I'll share that story with you, and I think it's what I'd like to always, what I want to underline here in this presentation is that when you do presentations for people with a medical background, and it's always a bit annoying, but I'd like to focus on the money side. Money is not free. You have to earn it. It's coming from somewhere. So please, don't become upset when it looks that I talk too much about money, but it's really about development and health. It's about how to make sure that there is more money in the system so that it becomes more inclusive. Everything that I do in this presentation is about this subject. This is also the whole focus of our activities as a group, as PharmAccess. And you should allow me for talking so much about money, because in the end it brings healthcare to the people. That is what I wanted to share with you as a starting position. This is, I think, the agenda that I wanted to present, and I'll run through it relatively fast, because I think in the last bit we are involved in something in Kenya with Safaricom and MPESA. That is really quite revolutionary, and I would like to spend a little bit more time there so that I have this maybe tradition that sometimes I'm not very clear, that you can ask me some questions that you understand better. But our roots to start with. This is the founder of the organization called PharmAccess, Pharmaceutical Access. It's good, I think, for young guys and girls here in this room. At the end of the 1980s, beginning of the 90s, HIV/AIDS became a massive problem, and it really appeared in San Francisco, New York, and also very much in Amsterdam. It was labeled as some kind of homosexual disease, and in the US, the government, Reagan-Bush administration, was not too fond of financing, and in the Netherlands, the Minister of Health in Amsterdam said we finance everything. So what happened basically is that the whole pharmaceutical industry, they came to the largest public hospital in the Netherlands. We are still based there. And there they did the trials. Of course, it was done in other places, but many of the large pharmaceutical companies came to Amsterdam for trials. So Roche, Bristol Myers Squibb, Glaxo, Wellcome, Gilead, all of them came to Amsterdam. And half of the 90s, after I think Joep met, through these trials, he had met Mike, Joep went to Africa and did in Africa the breakthrough mother-child transmission studies. And that, I think, is very relevant, especially when you look back. Not so much for doctors, also I don't think much for the people at Global Public Health, but for the general audience, that moment was a defining moment, those mother-child transmission studies, because it changed the disease, half of the 90s, from a extravagant homosexual disease in something with babies and communicable diseases, and everybody could get it. So there was a different vibe about this problem. And 7 years later, it was not for nothing. I'm always saying that it was President Bush who announced with the PEPFAR program tens of billions for HIV/AIDS treatment and changed everything. But I think it's important to take that back and to remember that this is happening. And as you all know, global health is about politics and it's about money. Again, this is the first time that you hear this thing about money. So it took 10 years, 1995 to 2004, 2005, before the first global assistance, global tax money became available for the disease. And Mike knows, and I think you all know, that this disease is a very good example of If you don't do treatment, you cannot do prevention. You're wasting, again, your money. You have to do treatment because otherwise you cannot do prevention. So he got involved in this in the beginning of 2000, and he called this initiative PharmAccess, pharmaceutical access. We made deals with the pharmaceutical companies. They gave us the price, they gave us the drug for very low prices, and we had to look for money. So, where do you start when you are working in Africa and you're a foundation and nobody wants to pay? And there's no public money. Where do you start? Anybody, any idea here in the room? Maybe you feel uncomfortable. I'll just give the answer. You start politically incorrect. You start with multinationals and armies. That's how we started. So the multinationals started to pay for their employees. The first one was Heineken. And they said, we pay for all our employees in Africa. And then a bunch of others followed. Diageo Guinness, Nestle, Unilever, Shell, Exxon, Coca-Cola, and we were running MTN, the big mobile operator, Celtel. So we were running at a certain moment on hundreds of places in Africa. We were running HIV/AIDS treatment programs. And HIV/AIDS treatment programs for people like you, again, has two dimensions. One is the medical side, so it's the location of the medicines, it's the training of the doctor, and it is the laboratory services. And then the most important thing actually is the money. You have to make sure that the money of Heineken is going into the patient and not somewhere else. You have to make sure, in our case, for example, when I was talking about the armies, the army of Tanzania, we still run the HIV/AIDS treatment program. We went there, and do you know how we are able to, as a small foundation, to run this scheme in a place like Tanzania? It's because the US military gave a contract to somebody that was not directly related to the Tanzanian armed forces, and the other way around. The Tanzanian armed forces didn't want to, share all that information directly with the US military. That's how a Mickey Mouse NGO in Amsterdam ended up with the contract. You need a trusted medical administrator. So, you need these two things, the medical side, pharmaceutical distribution, medication, lab and skills, and on the other side you need to administrate, a trusted administrator sitting between the risk taker and the patient. These two things is what the foundation has always been doing. Since then we grew into, just as a last reminder on HIV/AIDS before I go to the next slide, with that, we did, I think, from a global health perspective, we did something really relevant by doing these two dimensions, so schemes for multinationals and schemes for armies. We proved in those days, and there were a little bit of other groups, but not many, we proved in those days that private healthcare, privately financed for certain groups, delivered privately, can be something of public value. And that was something before 2005, 2006. Mike knows everything about it. That was something that you couldn't say in the space of global health. Because health has to be for everybody. It took the community 10 years until 2004, 2005 before we accepted that universal access means that somebody needs to pay for the people there. You cannot just take a plane to Tanzania from the World Bank and say universal access means we have treatment and you don't. So this is something that is not possible. And we demonstrated by having this private entry that private services, private payers can be of meaningful for global public health. And that's really what we have done. So we grew out of our medical administrative background, we grew into insurers, health insurers, and now I want to share something with you which is still one of my, that's probably the reason why I'm still doing this work 12 years, 13 years later. We run in Nigeria, we run this scheme for all these multinationals, nothing to do with armies, we were working for these multinationals. All big multinationals were using us, and we had one HMO that we were using to administrate the HIV/AIDS schemes. It's a group, is there any Nigerian here in the room? No, okay, it's a group called HIVAIDS. Sorry.
Behind the pillar.
Ah, yes. So, It's we're working with this HMO called HIGIA. Maybe you've heard about it. They are you have not. So they are the largest HMO today in Nigeria, and still, of course, it's not a very big group, but they are the #1 player. And what happened then is that the Global Fund was announced, and I think in 2003 it was established. It got operational in 2004, and the first disbursements were somewhere in 2004, beginning 2005. You know what happened? These multinationals pay, and through the insurer, you know what happened? Within a couple of months, all multinationals, with the exception of Heineken, stopped paying. And they said, well, you know, this is now a public service. You guys go to the public side, all the patients, and we stop paying. We stop paying for it and taking the risk. So what you see here in terms of global health is that you see a clear-cut example of crowding out. There's no better explanation, I would say, of crowding out. What happened is that the private payers, a bunch of private payers, were there, and they were paying for HIV/AIDS. These big insurers were involved, and then a public scheme comes and everybody stops paying, and the effect was that the money, public money, was being used by the higher incomes because they had to be referred. The employees had to be referred to the public schemes. At the same time, the banks in 2005 and investors in the insurance company, they withdrew their money because they were saying, yeah, you cannot cure this. These people, these schemes are not functioning yet, and the risk went up, and they didn't want to refinance the insurance companies. So you have a double effect of public intervention for HIV/AIDS treatment. It not only crowds out the demand side, it also crowds out the supply side, the banks and insurers that are financing those suppliers. That double effect was something that we couldn't understand, and I'm from Europe. I'm from a long history of health insurance, and in those countries to grow public, you have this mechanism of risk equalization. It doesn't matter. The use of public money should be for healthcare to reduce the unbearable and unknown risk. If you do it like that, then you crowd in money and people can take their own risk. So that's what we wrote a paper on. And we did that, and based on that, we got in 2006 a huge grant from the Dutch government to get health insurance up and running for low-income schemes. And then we had this money, and we thought we were brilliant, and we were working with these insurers. And then we had, and I think for people in developing countries, they immediately understand. And for people from the US or from Europe, they think, this is a big lesson. We discovered that when you subsidize something, so when you make insurance available, health insurance for those groups at low subsidized schemes, that people still are not willing to pay. Why not? Because they don't understand insurance, that's one thing. But much more important and much more elementarily, if there's no doctor there, if there's no medication in the clinic, why should I prepay? And this whole thing of prepayment and the fact that trust is needed in order to engage my money to a scheme with others, but first I want to see that the doctor is in the clinic and that there's medication there, that this is so essential, that resulted in the fact that we had to finance those clinics, and we didn't have the money. And then again, I think we did something quite remarkable in terms of not us, but in terms of finding some facts. We digged into, again, this financing need for doctors and for clinics, and we found out that 50% of all the care in developing countries, 50% is private. The World Bank, in the period 1997-2007, 10 years time, spent 12.8 billion on health. Out of the 12.8 billion of health, 680 million became available for debt and equity financing of healthcare, private healthcare. Out of that amount, $12 million landed in Africa. Yeah? So this is again one of those things you cannot believe your ears. And we set up a fund to finance doctors. I'll say much more about it later, but that's what we've done. And it's funded by Gates and Soros and Deutsche Bank. And I'll share with you later on what it is. It's called the Medical Credit Fund. Last but not least, we are since 1 year involved in the mobile health. It's Safaricom and MPESA, and I'll do something on that at the end of the presentation. This is what I wanted to share with you because I think it gives you some understanding of where we've been coming from. Now I'll give you a little bit more background of some of the details. We got an award for this fund by President Obama in 2010. We won an award with our article. It's called A New Paradigm for Health on Risk Equalization and the Role of Private and Public Money in 2008. And we've done quite a few publications. Just to share with you some facts. 47% of global communicable disease burden and less than 2% of the worldwide budget is available for Africa. This is on Africa. Then within Africa, you see, I mentioned it already, that 50% of all the care is private. The lower the income, often you see the more private it is. And here you see this slide that I mentioned to you, 12.8 billion for 10 years made available by the World Bank, and out of 12.8 billion, $12 million for risk and equity, for debt and equity financing in Africa. I repeat myself, but it's good to see this slide, I think. And then, of course, if there's no doctor in the clinic because they cannot afford to get a loan to buy medicines, then the result is, of course, that the out-of-pockets are the highest for the lowest people that need it most. The poorer you are, the more out-of-pocket you have. And this is an indication of the mirror of it. Only 5.5% of the people in Africa have access to health insurance. If you take out South Africa, it's dropped below 2%. And then we have this one-liner, what we always say as a group, our philosophy is that yes, if a patient is on his own and he pays for out-of-pockets and he sees that there's no doctor in the clinic, why should I prepay? And if I don't prepay, there's no risk pooling. And then nobody invests, because why should I invest in a bunch of people that are paying out of pocket? So there's no structure to bring together demand and supply. And we call this the vicious cycle of healthcare in Africa. I want to say something on before what we are doing, or what we really try in depth, to make two remarks. First is about the problems of exchange. So why in developing countries exchange is different from what you see here in the US or in OECD countries. That's on economic exchange. And two, why within exchange, because health is the largest industrial activity in the world, I'm always saying. In the US 17%, in my country 15% of GDP. So it's a massive activity. In developing countries, you have a problem of exchange in general, of economic development, and on top of that you have the problems of healthcare, which are a specification of economic exchange. I'll say something about that also. And then I go to our approach. We define from an academic point of view, we define development economics as exchange. And basically what we're saying is that problem of exchange is as a philosophy, I don't put my daughter in school in India because maybe I don't think I will make a return on it from an economic perspective. And so my discount rate is high. And this is one of the fundamental problems of developing countries. When you look to this slide of a market, exchange is on a personal level. When you look to this slide here, technology has changed everything. 10 years ago, it was not possible that you buy with a click through this site, you buy a bottle of wine in Chile with a transaction cost of maybe $1. So the impersonal exchange and the efficiencies that that has brought is simply unprecedented when you compare it with this. The waste in an economy is also unprecedented. And why is that? Why is it that this is possible and this is not possible? Why is it, what is the difference, the fundamental difference between those two systems? Just say something on this here. What is this? This is electricity in Kenya. I did a presentation last last Monday in Amsterdam, and a bunch of students like you, they said to me that this picture is not true. It was fabricated. But I think many people from developing countries, they recognize this. And what is this? What does it say here? it really says that everybody is freeloading. There is no real enforcement, because if the collector comes to my place, I just, for $10, $20, I get my bill out of the system. For that reason, nobody wants to invest. And as a result, everybody's sitting at home with a generator, and the market is completely and totally fragmented. And the cost of energy and the predictability are just massively higher than in this part of the world. So the collective issue of the risk related to, the issue of the risk and the investment and the efficiency is really totally lost, and the transaction cost in developing countries on electricity are massive. What is this then? This is, I think, one of the single biggest successes in development in the last 15 years. Everybody was saying, because I know some of the people of Celtel, Mo Ibrahim, he couldn't raise the capital when he started Celtel in 1998. You know why? They said to him, the development banks, the investment banks, he said, yeah, you know, you cannot run a GSM system in Nigeria. You cannot have a bunch of towers in Congo providing nationwide connectivity for GSM standards. That's not possible. And why is it that it has been such a massive success? And what is the difference with landlines? Probably, suddenly, technology made it possible that instead of a service postpaid, you have a prepaid, and it becomes a product. You can put it in stock. You don't have any more a collection risk. And for that reason, it attracted massive amounts of investments, and the free riding problem suddenly was gone. And then, what is this? Anybody here? And feel free to say, do you guys know, have you ever heard of MPESA? Yeah? You've heard of MPESA? Are there people who have not heard of MPESA? Please raise your hand. You have not heard of MPESA. That's very good. Yeah. That you're saying, you allow me to say something on it. MPESA means mobile money. So basically what it is that I have a mobile phone with a number, and I can put money linked to my mobile phone, and I can SMS the title to somebody else. I get an SMS with a specific number, I show it to a dealer, and the dealer gives me the cash. So I can transfer money from A to B against an enormously low transaction cost. That's really what it is. And it has been massively, unprecedentedly successful in Kenya. Today, 34% of GDP is running through this system. 80% of the people estimated is using it, and it has this enormous inclusive kind of mechanism. It allows people to pay for each other. They transfer money from Nairobi up country against just a couple of shillings. And it's, again, as I said, it is a massive success. So why is it that this suddenly is happening? Well, you are already registered. You don't need any identity card or whatever beyond your SIM card. People trust the mobile operator, and it allows you to pay for each other through this system. And it is, as I said, massively successful. Billy Jack did some real interesting research on this. So, last slide, which is very theoretical, and then we go to the practicalities. I think if you are interested in understanding this problem of transaction cost and enforcement, maybe if you're interested, you should read Douglas North, the Nobel Prize winner. He has this, he did this research explaining why in Europe, England and the Netherlands moved much faster than other countries. I think it's a fascinating study. And basically what he says is that when the state, and that's true of course, only for Europe, is talking, you know, we are very arrogant in Europe when we look to the US, and we look to the US and we say, in Europe you don't have nationwide health insurance. You're a bunch of capitalistic, non-social guys, huh? And then we look at them and we say, you know, you spend too much money and there's tens of millions excluded, and this is no good. And yes, maybe it is true, but the real point, and I learned that from a colleague, he's sitting there John, who was in the White House for some time, he said to me, you know, you have to understand that this is a trust problem with Washington. The people feel uncomfortable that the capital is redistributing on such a massive scale money. And then I thought, well, yeah, well, I think you guys are a bunch of capitalists. And then he came with a killing argument. He said, what is your willingness in Europe? What is your willingness in Europe, in the Netherlands, for example, to pay through Brussels for health insurance in Bulgaria? And it's 0. Yeah? And there, everything is set. The trust in the state is completely, totally crucial for building social services. And the central difference and the thing, what I just demonstrated with eBay or Amazon, is that when technology can change this all. And technology suddenly allows you to do things that were before only possible to do through the state. And that's really what I want to focus on in my next slides. I show you this one. As Douglas North is asking the question, how can neoclassical economics explain the bazaar and the souk? And what is then eBay? And the difference is that impersonal exchange is only possible, it's only possible when you have a state that acts in the interest of the people. If that's not the case, and let's be frank, it is only 50 years that this has changed in Europe, and I think the US needed a civil war before things changed. It takes a long time before that is happening, and technology can really, really change a lot there. So that is on economics. Then a little bit of remarks on the daunting complexity of health on top of all these issues and trust related to economics. This is a fascinating slide. I think we always call it the first law of health economics. Now I have to be careful in a room like this, because maybe people are saying, well, this is the 5th law of health economics, but we call it the first law of health economics. There's a direct correlation, I think it's 96, 97%, between the GDP and how much a country spends on health. It's a direct correlation. So that's nice, and it's good to hear. But what is so complicated about these slides, apparently, is that when you put in money externally, then apparently the total amount of money in the system is not going up. So if you decide that you're, I don't know, it's Tanzania, and you, as an international community, you put in a lot of money, then apparently the money goes from private to public, or is destroyed, or whatever. So the capacity is not going up. That is one of the consequences of this slide. So it's really difficult to come above that line. And again, I think technology is a big help there. The other thing here on this slide is that, yes, here we are spending 10, 15% of GDP, and here the problem in general is crowding in. Here the problem here is that people are on their own. There is no money to cover everybody, and there's this massive problem of getting an inclusive system. And here it's really about redistribution. This is China, and this is South Africa, many countries that are stuck in between. This is, I think, the most important one. It's called we call it the second law of health economics. The poorer the country, the more the people are on their own. Within a country, the poorer the people, the more they are on their own, and the higher the out of pockets. And again, as I said, for that reason, patients are on their own, the poorer they are. There's no risk pools. Because there's no risk pools, there's nobody investing in it. And our philosophy as a group is money, public money, should be used to increase the commitments of people to their own health systems on the demand side and on the supply side. We have a couple of examples of that. I'll show you how we're doing that. This is our philosophy. So we have a couple of interventions that we are trying to do as PharmAccess. We are subsidizing health insurance. We are giving loans to doctors. I think we are today one of the largest in sub-Saharan Africa. We've introduced quality standards for pharmacies and doctors against which we finance, in which we dispense loans. We do equity investments, and we do mobile to bring demand and supply together. just on our insurance schemes. We're doing that in Nigeria, in Nigeria, in Tanzania, and in Kenya. It is delivered through private HMOs, public money, and then we try to study how much people are willing to pay and how to share services with each other. SafeCare are our international standards that we have developed together with the Joint Commission. We measure quality improvements at clinics. So we introduce those clinics that can never meet the JCI accreditation standards. If you do that in Southeast Asia or in Africa, 99% would fail. And here we measure the progress and we measure how clinics are doing relatively to each other. This is our medical credit fund, the loans for doctors and pharmacists. Basically what we've said here is that if you take out, it's again about trust, if you take out the first loss, we don't know, in Africa it's not known what the loss is for a doctor, whether he will pay back his loan or not, what your default risks are. So we said, okay, let's say it's 10%. And we got money from USAID and the Dutch government as a first loss. We put it in a fund as equity. And then we crowded in capital from private funders, Soros and Gage and Deutsche Bank and OPIC and Calvert in the US. And then on top of that, we have money from local banks in Africa, in Kenya, Tanzania, and in Ghana and Nigeria. And we have been able to use $2 million of public money from large, in this case, donors, to leverage it to 60. So it's 30 times leverage. I think it's very efficient, and it's something that is not a genius by us, but it's again this fascinating thing that public money is used to crowd in capital. We've done this in Europe and in the US by the hundreds of billions to save our own banks and insurance companies. Then we go to development, we don't do it. This is a fascinating subject. Why is this not happening? On mobile, today we are working, as I said, with Safaricom and MPESA. We're trying to bring, to develop a system where people can have an electronic health wallet on top of the financial system, on top of the MPESA. Here you bring in all the payers, here we have the clinics contracted them, and then we have, it's run through an exchange, a health exchange, and that's basically what we're doing. Here you get the online details, you see how people behave. We have a pilot running with 10,000 people, and we have at this moment 1,200 clinics on the system. So it is rapidly developing, and I think this is a fascinating subject on solidarity. Here you see that people start saving, they start to share risks, and the most important thing is that health insurance until now was something that you use on a negative moment, and in mobile suddenly it becomes a possession. It is something that you can see the value of it, and it becomes something completely different. I think this is the future of health. I think there's lots of things happening in this space. It is real time, it is about solidarity, it is about risk reduction and trust, and I think this is really where things are moving, at least from my perspective. So this is what I wanted to share with you, and I hope you found it interesting. If you have questions, please feel free to ask them.
Thank you. So why don't you just go ahead and ask, my only request is say where you're from, what you do, or anything, just so he knows when you ask the question. Please, yes, anyone.
Please.
My name is Nanjala. I'm a second-year master student in the Global Health Program, and I'm from Kenya. And I had two questions for you. So one of the questions I had was, you said you provide loans for doctors in Africa.
Yes.
So I was curious to know, is this for postgraduate education, for opening clinics, and like what's the money for?
Yes.
And secondly, I wanted to know about like your partnership with MPESA. I know MPESA has other two products, M-Shori and M-Copper.
Yep.
I don't know if you like looked at. I mean, that's sort of like, you know, you can be able like to borrow money from Safaricom and then refund it after a while. Do you think that is working?
Yes.
And did that like motivate you guys?
Yes. Very good question. That was a very good question. So the lady is from Kenya, and The first subject I think is on the usage of MPESA and the loans to the clinics. So we are giving loans to clinics, and until now we did the loans through our banks. And so we are working with there's a bunch of banks, but one of them is sorry. Yeah, we're working with KREP and Chase in Kenya, and now we are moving to a digital system. Yeah, so we are seeing what is happening, and you see the payments, and now it's becoming possible. And that was her second question. And today it is possible in Kenya to. I'm looking for my mobile, but it's today it's possible in Kenya not only to pay, but to have on the spot, based on your history of a year, 2 year, you just click and you get a loan, and it's called M-Swari. And is it possible, the question was, is it possible that this is also that this will happen for doctors, or for students, or medical students, etc.? And this is exactly the thing that we are exploring, indeed, yes. Yeah.
On that subject of instant loans, the U.S. is actually going that way with cars, and you can go right online, and depending on your credit rating, you can actually get the loan that day, versus having to go through the bank. So I guess we're learning something from them.
Absolutely, sir. I mean, I think, but that is for us. I think we're really learning something here. I think it's one of the things that you guys with Duke are really, Krishna, where you're interested in. We're learning that technology is having social functions and brings economies of efficiency that we have sorted out in many other ways, and it becomes much more feasible and easy to use the systems that they have. I mean, why should you? And I think every Kenyan agrees, if you look at what M-PESA is doing, why should that not be allowed to have that here in the US, where we still have a check-based system? It's the banks that I think don't want this. So, yeah, you're absolutely right. Yeah, sir.
Hi, my name is Titus. I'm a medicine resident, and I'm also from Kenya. This is excellent. I had not heard of PharmAccess until I came here, and it's actually just transitioned in the past few years. And the presentation is wonderful, especially the comment or the statement which you made about the exchange and how it happens, and it's really based on trust, and that's such a fundamental thing that it's what has made, I think, Safaricom and M-PESA successful, is because people have trusted it. To put this into perspective, it is one of the most expensive money transfer systems in Kenya. Yet people would go, and I would not use my bank to transfer money, I'd use M-PESA just because I trust it more. To put this into now onto the next level is, you've spoken about safe access, and it caught my eye because it's one of the things that at least I know the health industry has been challenged with taking care of in Kenya. How to implement standards of care, standards of service, and not get it all confuddled in regulatory frameworks and saying you need to meet this, get a license for this, get a license for that, get 15 different licenses to be approved to be this level of care, or gets muddled up in bureaucracy. If that's the case, and safe access coming in as an intermediary and trying to nurture this trust, how do you navigate that path?
You know, I'm always saying that, back to your first point on trust, so I produce a little bit of a cloud, but I think it's important that we understand each other. I think when you're from a country, you're studying now here, and maybe you've been raised here, I don't know, and you only have spent a little bit of time in Kenya. Otherwise, you understand, I think, even better, is that yes, development is very often done by people that have been raised in a system where the state functions. And I think neoclassical economics, whether it's Keynes or whether it's von Hayek or whether it is Krugman or whatever kind of Nobel Prize winner, everybody implicitly assumes that the state acts efficiently. And that is, of course, very often not true. And we are very arrogant about that, I think. You know, in my case, I think in our case, I'm, again, as I said, I'm from a Mickey Mouse place, but I lived in Nairobi for some time to do this mobile stuff. If you see the criticism, you know, from Westerns for the tribal system and that is going on in Kenya, but in my case, you know, in my country, it was the Germans who had in 1942 had to introduce this problem of trust to introduce nationwide health insurance. So the matter of trust is something that it is something that, yes, you have to understand, you have to agree that you want to trust each other. And it takes a lot of terrible experiences before it's there. And again, technology can change that, I think, to a very, very large extent. Now, the second part of your question.
Sure. As a entity coming in and has done a
yes,
very
on SafeCare.
great,
yes,
has played a big role in mediating and getting the investors on one side and the patients and clinicians.
Yeah. So
how to now hold the stick?
Yeah, the thing is there that again, I think it's the same for HIV/AIDS treatment. That was such an enormous change that it took 10 years before money became available for treatment. With 20-25% of the population in Southern Africa infected. It's the same here. Why is there no private money available? Because people don't want to accept that private is a big thing when the state is not taking care of everybody. You know, informal sectors in the slums of wherever are a reflection of, as Douglas North calls, exclusion. You don't want to have them included. I'm always saying here that tomorrow, the Global Fund, tomorrow, they can give the people in the slums of Nairobi, or in Kisumu, malaria treatment. But why are they not doing it? It's because of the interests. So SafeCare, you call it safe access, but the standards that we're using, we use it to bring the private clinics into the public system. And you see very often that the local states, the local governments, that they are much more proactive than the external, the WHO and others. They don't want it too much because private healthcare is not good. But in the countries, you see massive interest in this. In Tanzania, in Kenya, in Nigeria, in Ghana, we all have these contracts because it brings those clinics into the system. And yes, we are in Kenya, we have a contract to bring all the clinics of the National Hospital Insurance Fund into the scheme. Yes.
Hi, I'm Joe Egger from the Global Health Institute. I was wondering if you could talk a little bit about the role of research or
yes.
rigorous evaluation in your work. When do you do it because you want to do it? When you do it because the grant funder expects you to do it? Or otherwise?
That's also true. But no, but we are really seriously into it. We just spent a lot of time with your colleagues at Behavioral Economics. Yeah, you know, if you have to understand better why people make certain choices and on what do they spend money and why do they spend money and how do they spend money, and to do research on that, I think is massively important. So I think one of the studies that we want to get in, that we really want to get into, is just a study published in the New England Journal, I think a year ago, that in Tanzania, I think it's 25%, but I'm not a scientist. I think it's 25% of all the health expenditure are on malaria. And then apparently, out of studies, it shows that 50% of the 25% is wrong diagnosis. So that's 12.5% of the nationwide budget. That is something that can be changed easily. You know, it's not you guys go out there and you make a payment system that rewards for, and it's not a rocket science. These are the kind of things that we have to work on and to make sure that it works. So, to make an analysis of a problem and to know where you stand, and then finding a solution and testing it, and then seeing how much it brings and saves, I think is the only way to get markets function for the poor and get more money in the system. That's what I believe in. That's what we believe in.
So academic research tends to be good, but it also tends to be pretty slow. So I'm curious to know, are you able to feed back at a pace that's quick enough into your own work to use evidence-based research to actually change the activities you do on a daily basis?
That's a very good question.
I see you struggling with the answer.
No,
It's a question we know.
but there's a difference between evidence-based and testing. We tend to shift much more to testing to see what works, and then we're not so much interested as an entity in the proof. I just want to know that my cost benefits are better to go this direction instead of proving that because then I'm in 4 years I'm still not done. But having said that, there are many examples where I think a deep understanding and real evidence also makes a hell of a difference. So for example, we've done an extensive research for 5 years, Michiel, in Nigeria.
It was actually, it was supposed to be 5, but it of course became more than 6.
Okay, so it's 6 years. So we did a correlation, we did a big study on in Kwara state, which is one of the poorest states of Nigeria, on health insurance and access to health insurance and blood pressure and lowering of blood pressure. And it was published in JAMA, I think a year ago, and it's one of the few studies done for black people and their correlation and sensitivity for high blood pressure and in this case interventions and health insurance because they had access to it. And for that reason I think it was published. So that is what we're doing, and there we're really trying to find evidence. But you know, I mean, in HIV/AIDS treatment, we have done it on resistance. So I think we have 7 or 8 papers, I think, published in the Lancet. But it's expensive. Nobody wants to fund it. And again, the multilaterals are not too much interested to hear that there's resistance problems. I think it's not easy to find the money. Also.
Hi, I'm Daniel. I'm in the master's program and I'm from Kenya.
From Kenya?
Yeah.
Okay.
You were talking about trust and the government, which doesn't really exist in Africa, mainly because of corruption and things like that.
Yes.
Do you think that you could use mobile banking in order to distribute, for example, international aid funds and things like that directly to the source in order to skip through levels in which you would lose control?
Of course. Okay. Of course. I think it's not that we're talking about whether we are a bunch of genius. No, it's just a matter of time. Everything, nothing is impossible, especially when it's inevitable. And this is going to happen. This is going to happen. It's a matter of time that we are sitting here and you just transfer money straight into the wallets of the people there for education, for food, for anything. Yes, it's going to happen. And it's already happening. So it's a matter of time, and we are just, I think, sometimes not aware of what the hell is going on there. No. Really?
Do you know of any examples of things being pushed through any global legislature or anything like that, like WHO, UN, anything? Are they looking into it, or?
Well, it's the same question as on the research. In my opinion, now I'm a bit critical, but I'm critical in terms of putting it into perspective, at least from our side. I think I was saying it with Mike or with some of your other colleagues. When you look to Amazon or eBay, and it's basically a spreadsheet and some guys with a PowerPoint, then you don't know what to research. Then in the next phase, yes, it is up and running, and you see it and it works, but still it's difficult to do research on it. And then only then, after it's there and it works and it functions and you have proven that the delivery works and etc., then you can start doing research. So these new kind of things that are pushing the boundaries of global health, I really think it is. You cannot do a lot of research in terms of proving things yet. But is it going to happen? Yes. Why? Because it is much more efficient. So it's a matter of time.
Last question in the back.
Okay. So, yes.
Hi, I'm Jenny Cook with Innovations in Healthcare. You had talked earlier about the problems of exchange, and you used it as an example, not sending your girl to school in India. I'm kind of curious about if there are there's a lot of research coming out about direct investment to women, and including women in these decisions and long-term policy things.
Yes.
What is PharmAccess doing what sort of intentional work are you doing around investing in women?
Well, I'm presenting here, but the organization is run by women. So that's, I think it's important to, yeah, because I'm only allowed to say something externally, but not internally. So I think that's important. Having said that, risk pools and the responsibility for children, as everybody knows, Esther Duflo shows it everywhere, is taken by women. And so we are trying now to, or not trying, we have these wallets, mainly for women in Kibera, where they can save together and dispense money together and decide together. And it's for women groups of 10 to 15 people, and it's a massive success. So that's really important. If you look to the medical credit fund, this fund that where we give loans, we're doing that together for the Kenyans in Kisumu with KMET, which is a very well-known large women organization in Kisumu and surroundings. So yes, we are trying to work on that as much as possible. We also think that maternal care is one of those things that can be in this system one of the most elegant ways to address a massive problem and also attract willingness to pay. So this is the kind of thing that we're doing. Yeah.
So Onno, before we close, in 2001, when you thought about this idea, did you think this is where you'd be now? Have there been surprises along the way?
Of course, yes, no, many, absolutely.
And what surprised you the most? What's been the biggest?
Well, what surprised me the most, Mike, and that is, I think it's a very good question, and it's probably, but now I'm speculating, it's probably the reason why you are also here in your job, but I don't know. But why am I doing it? I couldn't believe the double standards, the fact that people go to a country and you have a problem on treatment, HIV/AIDS treatment, or you have clinics where people cannot access any capital, that this is massively used in our part of the world, and then suddenly in development it's not. People taking with tax money, our tax money from Western rich countries, go to a developing country and they say, yeah, you cannot have a treatment because it should be for everybody. Those double standards are just unbelievable, and that's why I'm doing this work.
Well, thank you for doing it, and thank you for being here with us. It was wonderful. I hope all of you are enthused and ready to set up your own PharmAccess.